Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today, I'm joined by Chuck Ingoglia, President and CEO of the National Council for Mental Wellbeing, the unifying voice of America's community mental health and addictions treatment organizations. Together with more than 3,300 member organizations, they serve more than 10 million adults and children living with mental illnesses and addiction. Chuck, hey, how are you?
Charles, great to be with you today.
Yeah, I tell you, sometimes it's unfortunate that we're doing this audio only because people can't see what I see, which is a lovely, lovely backdrop. Chuck, if you can describe it for our listeners, if you would, please.
Well, I have a lovely picture of the cherry blossoms around the tidal basin, which were in full bloom last weekend, and they're always gorgeous.
Now, is that stock or is it that has to be stock? That's not an actual.
This one is stock, but we did have peak bloom just this last weekend.
So it's stock, but accurate stock.
That's right. That's right.
Okay. Good to know. Anyway, Chuck, really do appreciate you spending time today with me.
My pleasure.
So, before your current role, you were with the National Council for Community Behavioral Healthcare. You were with them for 17 years. I'm always curious how people gravitate to this work. What attracted you to the field?
Well, Charles, I've told the story before. Growing up in Michigan, I don't know that I knew what a social worker was, but I moved to Washington, D.C. in the mid 80s. And if you remember, that was around the time that homelessness was beginning to explode around the country as different federal programs were being phased out. And I started volunteering at a shelter for homeless women. And I was very confused as an 18-year-old kid, and I couldn't figure out why these women, who some of them really seemed clear to me had serious mental illness, why weren't they in some kind of housing support or treatment? And just being the kind of inquisitive person that I am, I started hanging out with the other social workers there and eventually chose to get into social work. And specifically, I wanted to get into policy because I saw that the systems weren't really serving these folks. So here we are, almost 40 years later, Charles, still tilting at windmills, trying to make the world a better place for people living with mental illness and substance use challenges.
Yeah, it's kind of interesting because you could win a battle, but it's a war you could never really win.
Well, I think it's, the United States really has to wrestle with the fact that we don't have a healthcare system. And since we don't really have a healthcare system, we really don't have a mental health care system either, right? And people say things like the system is broken. That would imply there was one, and we have a scattershot approach to healthcare in general, and and we all suffer from it, right? I think there's great data that just came out on NPR. I heard yesterday that wealthiest Americans live only as long as the poorest Northern Europeans. And so we spend a lot of money on healthcare in this country, but we don't really have a lot to show for it.
Tell us a little bit about your organization, National Council for Mental Wellbeing, its mission, and your role.
Yeah, so the National Council is an incredible organization. We were actually started in the late 60s, early 70s by, if you remember at the time, in 1963, the notion of community mental health was still kind of new. And the last bill that President Kennedy signed before his assassination was a bill to actually build a network of community mental health centers around the country. There was this vision that we could get people out of institutions into comprehensive integrated care in the community. And the National Council was the association that was started by those pioneers. And I think back to what that must have been like, right? I mean, any of us today, if we have to try to figure out something new, we go on YouTube and we ask, like, show me a video of how to do X, Y, or Z. In 1967, 68, 69, those things didn't exist. And so the National Council was the original kind of body that helped these community-based organizations figure out what it looked like to serve people with mental illness in the community. And we've continued to serve that role as mental health and substance use treatment has continued to evolve. Every state has a different way that it approaches the financing and delivery of mental health and substance use. So we've grown from representing those initial almost 800 community mental health centers to, as you point out, around 3,300 organizations now that serve low-income individuals. with mental health and substance use challenges.
Your site mentions your mental health first aid program, which has been used to train more than 3 million people in the U.S. who identify, understand, and respond to signs and symptoms of mental health and substance use challenges. Tell us about this program.
Yeah, so it's not our program. Actually, it was created in Australia by a woman a woman who's a nurse, and her husband is a mental health services researcher. And at some point, this woman named Betty Jordan, she had her own mental health challenge. She was a nurse working at a hospital, and she had an episode of depression. When she came back to work, she found that her coworkers really had a hard time talking to her. They didn't feel comfortable talking to her about what she had experienced. And she reflected on this. She thought, isn't it strange? Most of us are much more likely to experience someone having an anxiety attack or a depressive symptom or a substance use challenge than we ever are going to encounter someone who has had a heart attack. And yet many of us are trained in CPR. We understand what to do if we encounter somebody who has a heart attack. And she and her husband had this idea 25 years ago. We're celebrating the 25th anniversary of mental health first aid this year, that we should create a program that average people can come to understand what mental illnesses are, that they're real, common, and treatable, and be more comfortable engaging in conversation with each other. And I love when I hear from people who've gone through mental health first aid that they've noticed that there's something happening with their neighbor. And because of their experience in mental health for taking mental health first aid, they've gone and had a conversation with them, and that person's now in treatment and doing better. Or people who talk about it for themselves, how it's helped them. So that's the nature of the program. And actually, we're up to 4 million people have been trained in the United States, and we're close to 9 million people trained globally. Mental health first aid is in 28 countries right now, including the U.S.
Oh, it's amazing. Chuck, this is a two-part question. Try to keep it simple, but occasionally we got to do these two-part questions. Your organization has been a leading voice in Capitol Hill with a 55-year history of driving policy and social change. This is what you were saying at the outset. You recently wrote a LinkedIn article titled Medicaid Fact and Fiction. The truth is Medicaid works. That's the subtitle. In the current environment where Medicaid funding is, clearly under threat, what is likely to resonate with lawmakers in making the case for funding, again, in this environment?
Yeah, so maybe just take a step back and say a couple of things. In the 1980s, after the community, what was then the community mental health center movement was defunded at the federal level, a group of folks in Washington who were advocates for mental health got together, and they decided that the next opportunity really for scaling mental health in the US was this newish program called Medicaid. So if you remember, Medicaid was only created in 1965. So at that point, it was only like 15 or 16 years old. And they thought, well, maybe this would be our opportunity to really enhance the scope and coverage of mental health services. So I want to emphasize that this was some advocates. Chris Koyanagi and Howard Goldman were the people who wrote this article that appeared in the Journal of Psychiatric Services. And then they started working with state advocates around the country. And over time, we're now at a place where Medicaid is the largest purchaser of mental health and addiction treatment. And I tell that backstory because it's not like anybody in Washington, like in Congress, woke up and said, hey, let's make the Medicaid program, the premier mental health and addiction treatment. It just kind of evolved over time. And it's really interesting. If you listen to the current dialogue, there is a commitment from both sides of the aisle to not cut the program. I think where we might have some disagreement is we hear talk, I think, from one side to say, let's look for efficiency, let's get rid of fraud, waste, and abuse. And obviously, everyone can agree that those are good things. And it's also true that Medicaid has the amount of money that Medicaid spends on administrative tasks is so much lower than private health insurance. And so in terms of efficiency, it's hard to know where that efficiency will come from. It's already a very lean program. And number two, I'd say, certainly there are a considerable amount of effort to get rid of fraud, waste, and abuse in the Medicaid program, and that is certainly called for. Unfortunately, most of what gets characterized as fraud, waste, and abuse is simple clerical errors of notes not signed or dated or simply omitted. It's not kind of organized efforts to defund the program, to defraud the program. So I was one of the, you asked me a two-part question. I'm going to kind of give you, bigger picture. And what matters in this environment, anybody who's listening to this or who cares about the Medicaid program right now, just being in touch with your elected officials to help them understand the important role that Medicaid plays in the delivery of care. What does this mean for the people you serve? What do they actually look like? I think sometimes these conversations become very theoretical. I remember years ago, we had these conversations, state legislators would have these conversations around wanting to have co-payments for pharmaceutical products in the Medicaid program. And they said, well, it's only $1. And if you help people understand that sometimes people are taking 10, 12, 15 medications and they only get $300 a month, that $15 is actually a lot of money, right? It's a large part of their disposable income. So telling the story of what Medicaid does, why it matters, and what the consequences are of not having Medicaid are probably the advice that I would give to folks.
Yeah, you anticipated the next question I was going to ask you, which
I'm
is
sorry.
precisely about storytelling. No, because that's one of the things we talked about, the importance. And I was going to ask you for some examples, but
Yeah, well, because I think it all seems very theoretical, and I don't think most people understand that the majority of births in the U.S. are paid for by Medicaid. Many middle class people, their parents are in nursing homes paid for by Medicaid. This is not like this program serves a lot of purposes and a lot of people benefit from it. And I don't think folks necessarily always understand that. And then what's the consequence, right? We already have a situation where too many people end up in the emergency room and or are being cared for unnecessarily in local jails. And I don't think either emergency rooms or jails want to see more people inappropriately in those settings. So those are just helping people understand what the consequences are of people not having access to healthcare.
yeah, it's interesting because Lighthouse and Chestnut has this Substack also called The Catalyst. And one of the things that we're looking to do is to paint these pictures, to tell these stories. And we did a piece fairly recently about Medicaid and to give a real concrete idea of the uses of that money. And once you see the programs and you see how they're bringing different elements of the community together and everybody's stakeholder, law enforcement, volunteers, et cetera, then you start to see the impact it has. But you're right, the conversation is usually at a very abstract level. It's really hard to sink your teeth into it.
Yeah, yeah. Well, I commend you for telling those stories, and I was just at a meeting today at the White House actually, and they're asking us today for stories of people who have benefited from these programs. That so that's the I just really encourage people to get people who are beneficiaries of the program involved and encouraging them to say why it's mattered to them.
Well, I just want to put it out there on record. I'm sure you have no shortage of stories to draw from, but we're happy to add to that arsenal of stories because we got quite a few. Because, again, I don't want to make this a commercial timeout for Lighthouse or Chestnut, but, that really is what they do, which is to say, take their research and they have their implementation scientists. They're doing stuff on the ground. gathering the information, coming back, calibrating, recalibrating, and making sure, it's a process, an evolutionary process. But again, it's important that we tell those stories, real people banding together, doing great things for the community.
Well, and I think, if I reflect on the 20 years that I've been at the National Council, the biggest difference that I have seen in those 20 years is that legislators actually get mental health and substance use in a way they did not 20 years ago. And the reason they do, right, is because think about all the attention that the opioid use epidemic has gotten from Congress over the last 10 years. The reason it's on people's radars is because legislators go home and they're hearing from their friends, their neighbors, their constituents about people they know who have become addicted or who have died from overdose. And the same thing for mental health. I think, there's so many terrible things about COVID, but it certainly put mental health on the radar in a way that made it, how many of us had family members or friends who experienced anxiety or depression or had other struggles during COVID. It really helped make it real for folks. And I think we got to continue to lean into that.
Yeah, it's kind of interesting. You mentioned 1967. We don't have the technology, the tools, communications platforms, social media platforms, that we do now. So now that we do, I think we can be more transparent. People have access to people telling their stories, and the more people tell their stories, the more, the less stigma and the more forthcoming they are. Which actually leads to my next question, because there's also that other side of this technology, particularly social media and the anxiety it causes. So, it's always that balance. But I don't necessarily want to talk about specifically, but I do want to talk about the intersection of AI and mental health. Obviously, we're living in a world right now that people are describing as AI augmented work, or an AI augmented world. It's a reality. And we know it has potential to help on the clinical side. It has to help to engage people. But there's also some challenges, and there are also some issues. What are you hearing, and what do you say to that?
Yeah, it's been interesting, Charles. I'd say over the last 3 years to go from kind of this general kind of almost skepticism about AI and to where I think now there are certain use cases of AI that are being broadly embraced. And think specifically of, are there ways that technology can help us be more efficient in the way we deliver care? And the big thing that I keep seeing is the assistance that AI can give clinicians in summarizing clinical interaction and producing compliant notes, so that clinicians can spend less time having to do that documentation. They still have to review, approve, augment those notes, but certainly we're seeing lots of organizations around the country begin to use AI technology to support that. And then I think, and I think it's important, right? Because we also at the same time are having increased need for care while we have fewer professionals available. So anything we can do to drive up efficiency, I think people are really embracing that. I think the other areas where we're seeing technology is, and then so if you're taking, AI is helping clinicians to generate first drafts of notes, then that technology could also help you make sure that notes are being submitted on time, that they're being done in a way that won't cause any red flags, and so that billing can happen in a way, again, that doesn't cause any difficulties down the road. And then there's one of the earliest uses of AI actually has been to kind of chatbots to support people with mental health challenges. I think that one is still, probably a long way from being fully and supported, but certainly we see some uses of that. The other one that I'm kind of interested in is, how can AI help clinicians make better treatment decisions? So taking the information from assessments and offering guidance to clinicians about treatment approaches. So, I mean, lots of interesting things happening. Charles, I'd be curious what kind of led to this question. What are some of the comments or concerns that you're hearing?
Well, I've heard one. It's kind of interesting. In fact, I recently had a podcast. The woman is a psychiatrist. She also consults on AI governance. And you'd think, well, how do they come together? But she also talks about, sort of behavioral psychology and making sure people are doing, the right thing. But one thing she brought up is that there's this duty to warn if somebody's expressing suicidal ideation and you're on some sort of chatbot. What's the functionality? How do they facilitate that handoff, or how do they do that notification?
Yeah, and I think that's a great example of the kinds of real world uses that we still have to figure out. And I think there are probably ways that technology can help support efficiency. When we get into, can it actually deliver treatment? I think that's where it gets a little more interesting.
Yeah. And, efficiency is sort of a double-edged word right now because, I talked to some vendors, AI vendors, and I say, you really want to be careful about that word. It's sort of a loaded word in this world when people are afraid that because of efficiency, you're going to be out of a job because that's what AI brings. So you may want to be careful about using that word.
Yeah, well, I'm not thinking about it in terms of replacing humans, but how do we help humans be more effective and efficient? Because I don't know any clinician that loves doing paperwork, that loves writing notes, right? So
No,
if there's something we could do
no.
that takes away that burden, I think most folks are pretty excited about that.
It reminds me of the old bit. Nobody on their deathbed says, "Ah, I should have spent more time at the office."
That's right. That's
You
right.
know. Any organizational initiatives, closing thoughts you want to share?
Well, certainly, I would encourage folks, if you're wondering about the future of Medicaid and how you might get involved, I would encourage you to go to the National Council's website. We have a place where you could be kept up to date on what's happening in Washington, and also there are ways that for you to get engaged, to reach out to your members of Congress. We try to make that very easy for you. Charles, you asked a great question about mental health first aid. If you're interested in learning more about mental health first aid or bringing it to your community, where you can also go to the mental health first aid website and learn more about that. And, I think we have a host of resources on the National Council website, everything from measurement informed care to integrated care to a variety of things around workforce. Please check it out and let us know what you think.
Yeah, no, great. By the way, you said you were at the White House this morning.
I was.
Would it be naive for me to take that as a positive sign? Because I do think that there is this widely shared perception that this administration is operating sort of in their own bubble. They're not engaging people from outside organizations that may not at first blush be aligned with their agenda. So would it be naive for me to look at that as positive?
My sense is this administration is continuing to build out its team, and we were there actually, just to do what you're described, Charles, to say this is who we are, this is how we can be a resource to you, and please keep us in mind in the future. So, and we were met with a lot of enthusiasm. So, we're at the beginning of an administration, the beginning of a process. A lot to continue to unfold and to learn from.
Yeah. Anyway, Chuck, I really do appreciate the time you spent with me today. Thanks so much.
Well, thank you for the opportunity. Take care.
Oh, for sure. Today, I spoke with Chuck Ingoglia, President and CEO of the National Council for Mental Wellbeing, the unifying voice of America's community mental health and addictions treatment organizations. Together with more than 3,300 member organizations, they serve more than 10 million adults and children living with mental illnesses and addiction. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.